been a valuable asset to European Respiratory Society for many years now. She started with asthma, pediatric asthma chair, secretary chair, and then now she's the chair of Pediatric Assembly of the European Respiratory Society. She's been a great asthma researcher now for a long time with many publications in prestigious journals, including Blue Journal, ERJ. And she is working at Erasmus University in Rotterdam, which I had the chance to visit for one of the task force we worked together. And Nilay was there also. So it's really great pleasure to listen to Marielle. And I shared this link with my friends here at Arva as well. But like everybody's working now, the clinics are still on, but I will share the link. I don't think they are able to join now, but I'll share the link with them as well. Thank you for accepting this.
Well, thank you so much for this very nice introduction, Bulent and Rafika. It's really a great pleasure to present this evening. I discussed earlier with Bulent, I think it was 5 years ago that I went to Istanbul, which was a really very nice visit. Not only because of your annual conference, but also because of you are really very nice people, all of you. I enjoyed the music and the food, so it's a shame that we cannot meet personally. But I hope we can meet at least in Barcelona at the ERS conference in September. But well, we will see. We are trying to organize a face-to-face meeting in the end. So I'm going to try to share my screen. Can you see something now?
We can see your PowerPoint, but it's not in full screen.
Oh, okay, yeah. And I have to click that probably. So it should be on full screen now. Is that correct?
Yep, it's on full screen.
Okay, thank you. So I have one declaration of a conflict of interest. That's I did some consultancy work for Sanofi Genzyme. So this evening I would like to present on severe pediatric asthma, and I will start with the definition of severe asthma and an example how to assess a patient with severe disease. Then I will talk on the pathogenesis of asthma, because that's important, because otherwise you can't understand how biologicals work. And most of the time I will spend on the treatment of severe asthma, in particular with biologics. And I will end up with a summary and some recommendations. To illustrate the burden of disease of severe asthma, I would like to introduce you to one of my patients, Isa. She's a 14-year-old girl, and I know her since the age of 2 to 3 years, when she presented with several episodes of dyspnea, wheezing. We could not find any allergies, and she had a low total IgE of 12 and slightly elevated blood eosinophils of 0.3. During the years, I treated her with high doses of inhaled corticosteroids, long-acting beta-agonist, montelukast, but frequently she had uncontrolled asthma. At lung function testing, we saw reversible airways obstruction at several occasions, and a maximum NO was 71 ppb. A few years ago, we did a bronchoscopy to rule out other diseases and other abnormalities, but bronchoscopy was normal, and in the BAL fluid, we found 2% of eosinophils, which is elevated. We made a CT, which only showed some air trapping and no other abnormalities, and she presented well at least twice a year with a exacerbation for which she needed prednisone, although she had only few admissions. So I think this is one of the typical patients with severe asthma. Actually, there's no universally accepted definition of severe asthma, but several features are key in all definitions. In general, we exclude children below the age of 6 because an asthma diagnosis is difficult in this age group, as you know. Children need to require step 4 to 5 treatment according to JINA or BTS or national guidelines for the previous year, or systemic corticosteroids to prevent their asthma from becoming uncontrolled, or if their asthma remains uncontrolled despite this high doses of treatment. The asthma diagnosis should be confirmed, and the patient should be evaluated and managed at a specialized center for at least 6 months. And that's especially because then all those modifiable factors will have been addressed, like adequate adherence, inhaler technique, etc. Patients should be uncontrolled or need this high doses of treatment to stay controlled. And uncontrolled is defined as a asthma control test below 20 and or 2 or more exacerbations per year and or 1 ICU admission and or a post-FEV1 below 80%. So actually we are talking about the children in the highest steps of treatment, as you can see here in the scheme of China for children 12 years and older. In this figure, the management of severe asthma is summarized, and I will talk you through step by step. So in the left upper corner, first the diagnosis has to be confirmed, and we really need objective tests for this. So spirometry with reversible airways obstruction, or positive bronchoprovocation test, elevated FeNO, peak flow variability, but we really need an objective test for asthma. Second, children should be treated with high doses of inhaled steroids, like I already explained. And thirdly, despite these high doses of treatment, children remain uncontrolled, or they really need this high dose of treatment to stay controlled. And fourth, modifiable factors have been addressed, in particular adherence, inhaler technique, exposures like exposure to cigarette smoke or to allergens, and comorbidities have been treated as far as possible. And here, if there's no evidence of poor control, medication should be reduced to the lowest possible dose. This is an example of a specialized secondary care clinic in the Netherlands, in Zwolle. And what the authors did is they looked at all the children referred because of uncontrolled asthma on high dose of medication. And actually, if they looked at modifiable factors, they could identify such a factor in the vast majority of all the patients, in almost 98% of children. And poor adherence to treatment was one of the major problems in 37%, ongoing exposure to triggers in 28%, and in some children the diagnosis was not correct. So only less than 3% of children with uncontrolled asthma on high treatment step in this secondary specialized clinic had really therapy-resistant asthma. So if after going through these steps, patients have good control, we talk about children with difficult to treat asthma. So these are not really treatment resistant, but they have more a difficult to treat asthma because of psychosocial issues, of smoking parents, or of poor inhaler technique, etc. Children who have ongoing poor control after optimizing the treatment, they apply for an intense multidisciplinary assessment and often also for additional testing like hyperresponsiveness testing or bronchoscopy or maybe induced sputum. These are the key players in our multidisciplinary team assessment. I think the most important person is our asthma nurse. Before the patient comes to our clinic, she tries to retrieve all the data from the pharmacy to have an idea about adherence to treatment. She retrieves data from other hospitals. She sends questionnaires to the patients, especially questionnaires on asthma control, like the ACT or CASI, the adherence check questionnaires, quality of life questionnaires. Really important part of the MD assessment is education to the patient and the family. The nurse checks the medication, which medications did the pharmacy actually deliver. There's quite some difference in the Netherlands between pharmacies. She tries to identify and also prevent triggers, and the smoking parents are one of the most important triggers. And sometimes the nurse can go home to the patient and visit them at home, but in general in our system we have a sort of a first line service where nurses can go to the home or the school of the patient and see what's happening there. And that's really really important in the children with a real severe asthma. The pediatric pulmonologist is certainly not the most important person, but I think our role is mainly to do a thorough history and physical examination and to exclude other diseases or to check for comorbidities. Our psychologist is a really important member of our team. She looks at fears, anxiety, depression, but also at issues at school. And I think in our team, in our clinic, well, around 30 to 40% of children, there are psychosocial issues, which may be not the only problem of the children, but may it may increase the asthma symptoms and decrease the asthma control. And on indication, the children also see a dietitian, especially in the children with obesity, and a physical therapist, especially if there are problems during exercise. So very important is to find objective signs of asthma, but also to rule out other diseases. And here you can find some diseases in the differential diagnosis that are important. And I want to stress especially obliterative bronchiolitis. We had some children with bronchiolitis obliterans or obliterative bronchiolitis who were treated for severe asthma. We had one child with PCD, and also sometimes we find a tracheobronchial malacia. Hypersensitivity pneumonitis, we had some cases of that recently. And diagnostic clues are, of course, objective measures, but also signs at physical examinations like localized crackles or clubbing or murmur, of course. And all these signs can give you an idea about the differential diagnosis. So that are the so-called red flags. Comorbidities are important. Gastroesophageal reflux has been reported in up to 80% of patients. Most of them are asymptomatic, and actually treatment with lansoprazole did not make any difference. So that's the chicken and the egg discussion, I think. Food allergies, children with food allergies have more severe and sometimes even fatal asthma. Dysfunctional breathing is quite rare. Exercise-induced laryngeal obstruction we sometimes see, and in that case the ENT surgeon may be of help to diagnose that. And of course allergic rhinitis is an important comorbidity. Except for allergic rhinitis, a comorbidity we really see often is obesity, and obesity of course has a very high incidence worldwide. 20% of all the children worldwide have obesity, and this increases the risk of asthma with an odds ratio of around 1.3. However, the relation between asthma and obesity is a bidirectional relation. So children who are obese have a higher risk of asthma, but children with asthma also have a higher risk of obesity. And the mechanisms that have been suggested are simply mechanical. So the fat burden on the chest wall decreases your diaphragm movements and the chest wall mechanics. Dysynaptic growth is a phenomenon that's often seen in children with obesity. That means that the airways are not growing in the same speed, so to say, as the lung parenchyma. And this may lead to more severe disease, to irreversible airways obstruction and less responsiveness to inhaled corticosteroids. Obesity has been considered as a low-grade systemic inflammatory state, with a dysregulation or a disbalance between pro and anti-inflammatory adipokines, leading to an increase in Th2 cytokines. Of course, there's some genetic susceptibility may play a role, and also epigenetic mechanisms. And decreased activity, but also fear of getting asthma symptoms or an asthma attack when exercising may lead to obesity in children with asthma. And in the end, this may lead to deconditioning. oral prednisone courses play a role also in obesity. So there's a clear bidirectional relation, and this comorbidity is really very hard to tackle in my experience. If we look at further diagnostics, in general, we will do some lab tests, IgE and blood eosinophils, especially if you think about starting a biological that may help in choosing which biologic you will start. Aspergillus serology and immunology tests. If there are any signs of adrenal insufficiency, we will check for cortisols in the saliva, or a short ACTH test. We do extensive lung functions tests, including, of course, spirometry before and after bronchodilator, and in selected cases also bronchoprovocation testing. In many children, we perform ergometry, especially to have an idea about the exercise capacity and the possibilities of exercising in a child. A chest CT can be made to exclude, especially to exclude other diseases. You may find some, well, more or less typical asthma findings as air trapping, but in general, we make a chest CT to exclude other respiratory diseases. Bronchoscopy with BAL is only performed in selected cases if we have a real suspicion that there's an underlying disease like tracheomalacia, or we tend to do bronchoscopy more early in children who are not allergic, because in general you have more doubt about the diagnosis. And if we do bronchoscopy, of course, we also do a BAL, and we also take endobronchial biopsies to look at signs of reticular basement membrane thickening and of eosinophilic infiltration. And on indication, we also consult our allergologist, the dermatologist in children with severe eczema, and the immunologist sometimes, and especially in children with upper airway, lots of upper airway problems, or children where we suspect exercise-induced laryngeal obstruction, we also ask our ENT surgeon. So back to the scheme. So if you checked, if you're really sure that this is asthma and you checked adherence, inhaler technique, etc. So after this multidisciplinary team assessment, it should be possible to make a distinction between several groups of patients. First, if after this assessment the children do not have ongoing poor control, so they are controlled again, then we're talking about difficult to treat asthmatics. And in these children, you should maintain then on the lowest possible dose of inhaled corticosteroids to maintain control. On the other hand, in some patients, we consider another diagnosis and decide that it's not asthma. And I think that's in the patient we get referred, I think it's in 5 to 10% of all cases. Then you have the children after this MD assessment with ongoing poor control. And if you could address all the modifiable factors, these are the children with really severe therapy-resistant asthma. However, it's not always possible to address these modifiable factors because it may be really hard to tackle obesity, smoking parents, psychosocial issues. But still, these children might be eligible for a biologic. Even it might even save their lives if they have real severe asthma attacks. So for the rest of my presentation, I will talk about these two groups of children, the children with severe therapy-resistant asthma and the ones with refractory difficult asthma, and that are the children who may be eligible for a biological. But very important to realize that therapy-resistant severe asthma is extremely rare in children, and that these new treatments, these biologicals, are only for a very small group selected children. So I move on with some slides on the pathogenesis of asthma to illustrate how these biologicals work. Well, classically, severe asthma in children has been considered a typical T2 high disease with multiple sensitizations, high eosinophils in blood and in the airways, high FeNO. It's the classical picture of a child with allergic asthma. This is a very simplified cartoon, of course, but if you look at the upper left corner, allergens are recognized through TSLP, thymic stromal lymphopoietin. This stimulates Th2 and ILC2 cells, innate lymphoid cells of group 2, to differentiate and to produce interleukins like IL-4, IL-5 and IL-13. These cytokines result in the production of IgE by the B cells and subsequent activation of mast cells and degranulation of mast cells. And IL-5 and IL-13 activate and recruit eosinophils, which are the predominant cells in severe T2 high asthma. So this is the classical T2 high inflammation. On the right side of the slide, you see the more T2 low inflammatory pattern, which is dominated by Th17 and Th1 cells. Recent studies have shown that a neutrophilic inflammatory phenotype, which we often see in adults. In adults, this phenotype is seen in almost 50% of all the patients, that it may also be seen in children. So in the next slide, I have a summary of the recent studies in severe asthma. And what you see there is that up to 37% of children show neutrophilic inflammation and a more Th1, Th17 signature in BAL fluid or in biopsies. And of course, this may have implications for therapy, because inhaled corticosteroids or systemic steroids may be less effective in this inflammatory phenotype. However, it's important to realize that all the studies done in children with severe asthma are done in children who are treated with high doses of inhaled corticosteroids. And especially the IL-5, IL-13 are very sensitive to steroids. So maybe we are just looking at a very selected population of children where T2 inflammation is already suppressed. And the other thing is that this more or less neutrophilic inflammation is seen more often in the younger children, in the preschool children, and might be also associated with infections. So in this table, I summarized some studies showing that a neutrophilic inflammatory pattern is not very rare actually in children with severe asthma. But if this is a real inflammatory phenotype, or if this is actually because of all those children are already treated with inhaled corticosteroids, that's a difficult question. So which monoclonal antibodies, which biologicals are available at the moment for children? Well, in my country, and I think in most European countries, there are 3 on the market. That's omalizumab, which will be well known to all of you, mepolizumab and dupilumab. And in the anti-IL-5 corner, there's also reslizumab and benralizumab, but that's also only registered for adults, at least in the Netherlands. So I will talk a little bit on these medications. Omalizumab is on the market the longest time now of all the biologicals that I showed you. It binds to free IgE and blocks IgE receptor binding. It also increases interferon responses to viruses. I will show you in a few slides. It has, of course, anti-inflammatory properties, but also some effect on tissue remodeling. It's licensed by EMA from the age of 6 years for severe asthma, and you have to give it subcutaneously every 2 to 4 weeks. So at the start of omalizumab, we saw all the children in the hospital and gave them the injection in the hospital. But now there are pre-filled syringes, as you can see below, of 75 and 150 milligram. And most of our patients now get their omalizumab at home, and they administer it themselves. Omalizumab has been shown to reduce asthma exacerbation very clearly, very significantly, not only in randomized controlled trials, but also in real-world studies, as you can see here with all the p-values. And this is an interesting study, in my opinion, showing that omalizumab also can prevent the asthma exacerbations typically seen in the September epidemic. So that's I think the phenomenon will be the same in Turkey, but in the Netherlands and in the US, in the UK, we see an increase in asthma exacerbation in September, October, because children go to school again, there are more viral infections, the weather conditions are less favorable for children with asthma, and that's the period of the time that we see a lot of exacerbations. In this study, they started omalizumab in a randomized controlled double-blind placebo-controlled trial in more than 500 children, and they started omalizumab 4 to 6 weeks before the school start. And as you can see here in the left panel, there was a decrease in exacerbations in the proportion of children with at least one exacerbation in the omalizumab group. And this was actually driven by children on step 5 treatment, and this is shown in panel B. So the effect was more pronounced in the children on step 5, but also in the children who had at least one exacerbation during the run-in period. It was a 3-arm study, and the third arm, a higher dose of inhaled corticosteroid was compared to omalizumab and to placebo. And in the lower treatment steps, higher dose inhaled corticosteroid was equally effective to omalizumab, but not in the children on treatment step 5. Here you see that children, here I show that children, that omalizumab increases the interferon alpha response to rhinovirus, and that patients with a higher than median interferon alpha response on omalizumab have less exacerbations than the children with a smaller interferon alpha response. This was taken a little bit further in the PROS study. Again, almost 500 children with allergic asthma, and here usual care was compared to usual care with omalizumab in the fall seasons in 2012 and 2013. And as you can see, children in the omalizumab group had less illnesses, especially less viral illnesses, although the duration of illnesses was the same, was similar. What are the effects of omalizumab on other outcomes? On lung function, there's no real effect in the randomized controlled trials, but it was in most real-world studies. And in most studies, there's a decrease in inhaled corticosteroids or oral corticosteroids and an improvement in patient-reported outcomes. Also, healthcare resource use was decreased in most omalizumab studies, and children missed less school days. Because it's quite an intense treatment with omalizumab, it might be good to have predictors of response. And well, here are the predictors of response as shown in adults: high FeNO, high blood eosinophils, maybe remarkably also high BMI, all predict a response to treatment. And in the ATS-ERS guideline, it states that eosinophils above 260 per microliter, high FeNO above 90.5 ppb, may identify adolescents and adults with the greatest likelihood of response. Data on safety actually seems to be quite safe. No evidence of an increased risk of anaphylaxis or hypersensitivity reactions or malignancies. Adverse events are frequent but comparable to placebo and mainly related to the injection, but also some headache and some respiratory tract symptoms. But most side effects are mild and only a minority was treatment related. Difficult part is the cost effectiveness. It's really expensive treatment. 75 milligram pre-filled syringes is around 128 pounds. That's around 150 euros. I'm not sure what it is in Turkish lira, but that's really expensive. And per patient, if you treat the patient for a year with 2 weekly injections of 150 milligram, it's around 7,000–8,000 euro. You can express this in a incremental cost effectiveness ratio, which actually means what is the cost for every QALY gain, so the quality adjusted life years. It's quite a common term in cost effectiveness research, and that was really high, around £80,000. And in general, this is above the limit that is considered reasonable, at least in the Netherlands. So it's a really expensive treatment, and again, I don't know the price in liras, but it's an expensive treatment that can't be that's not possible in all countries. So in summary, for omalizumab, it is a very effective medication as add-on treatment in children with severe allergic asthma, and especially in the children with recent exacerbations on step 5 treatment. There are possible antiviral effects of omalizumab that may explain the effect on the September epidemic. And we really need more biomarkers to predict response in children, because most research has been done in adults. And it's not affordable in many countries, as I explained. The second biological I want to discuss with you is mepolizumab. Mepolizumab blocks to IL-5 binding to the IL-5 receptor on eosinophils and is licensed for eosinophilic asthma from the age of 6 years, at least in the Netherlands. You have to give it subcutaneously once every 4 weeks, and there are 2 separate dosages, 100 milligram for children 12 years and older, and 40 for children between 6 and 11 years. Studies in adults and adolescents show less exacerbations and a better quality of life in the mepolizumab treated group. However, data in children are really scarce. Actually, there are only 2 trials published on mepolizumab in children 6 to 11 years. And this actually was a pharmacokinetics and pharmacodynamics study and not designed for efficacy. It was a small open-label uncontrolled study, and only 30 children with eosinophils above 150, and children were followed for 1 year. It was a group of children with a lot of exacerbations, so the mean exacerbation rate in the previous year was 2.5. And half of the children that participated had been admitted to hospital in the year before the trial. Quite a lot of adverse events, but most of them were not considered severe adverse events, and from the 7 severe adverse events, none was considered to be treatment related. No anti-drug antibodies were developed, and if you look at efficacy, what was not the aim of the study, you saw a decrease in eosinophils during the treatment, less exacerbations, and improved control, which is shown in this figure where you see on the y-axis the mean change from baseline in the CACT, the Childhood Asthma Control Test. And as you can see, this increased during the study and decreased after stopping mepolizumab again. So only a small study in few children. The other anti-IL-5 treatments actually are not registered for use in children, and in the studies in adults, very few adolescents have been included, and there are no separate data available for adolescents and adults. Dupilumab is licensed for children from the age and in children 6 years and older with severe atopic dermatitis. So most studies actually are in atopic dermatitis. It blocks activity of IL-4 and IL-13. You also have to give it every 2 weeks by subcutaneous injection. And again, there are pre-filled syringes for dupilumab. The studies in adults, less exacerbations and a better FEV1. And high FeNO, high eosinophils seem to be predictive of response. And a phase 3 study in children is not longer ongoing, but is closed. And the first results are very promising, but they're not published yet. So I think I showed you that we only have very limited data in children, especially for mepolizumab and dupilumab. And why is that? Well, I think there are several reasons why children are not included in trials. First, numbers are fewer compared to adult asthma, and we have less possibilities to define asthma phenotypes because bronchoscopy is quite invasive. So it's more difficult to get a good inflammatory phenotype in children. Trials in general and trials on biologicals in particular, children engage often less well because these trials are really quite complex, and in general there are a lot of blood tests in the trials, which is of course not very attractive for children. And also legislation is quite complicated for children. So that was the reason to start with a clinical research collaboration within the ERS called SPACE, Severe Pediatric Asthma Collaborative in Europe. And this CRC is chaired by Franca Rusconi and Jonathan Grigg. The first result of these SPACE have been published, and I will show you in the next slide. So what were the aims of SPACE? Well, our first aim was to develop a pan-European database or registry of children with severe asthma to get more insight in real-life data and characteristics of children with severe asthma. But also this database should lead to better defined, better phenotype pediatric patients in order to develop an infrastructure that can be used to support trials of new treatments. So recently, this publication, AHA Open Research, showed some first results of SPACE. 80 children included in the database with a mean age of 13 years. Most of them were allergic, as you might expect. And 62 of 80 had suboptimal control, which was defined based on ACT or GINA or exacerbations. Of these 80 children, 18 were well controlled. Half of them were on a biological and the other half were not. But maybe this is not the most interesting group. I think the interesting group are the children with partly or poorly controlled asthma in this database. Half of them were not on a biological, although 24 were eligible. So apparently not everywhere access to biologicals is well is there, or costs may of course be a problem, or the children don't get to a asthma specialist experienced in biological treatment. But I think here is a group of children where we can improve asthma control. And on the other hand, 33 of those partly or poorly controlled children were on a biological, and of them in 29 we considered it possible to switch to another biological. So I think these, of course, small data sets already showed that despite the use of biological, quite a lot of children are not controlled, and that uncontrolled children with severe asthma, many of them are not on a biological. Of course, there are quite a lot of clinical questions. It's not always clear which biological you should use in which child. And after you start and assess the response to treatment, it's not very clear for how long you should continue, or if you can try to withdraw or wean from the biologicals, or if children have a poor response, if it's feasible to make a switch. We don't have studies comparing biologicals, although they are ongoing, and we have very limited data on mepolizumab and dupilumab. This slide is based on GINA, where GINA gives some suggestions on how to make the choice between these 3 biologicals, and of course this is based on adult data. Children with in yellow, you see our typical population, allergic or eosinophilic asthma with a lot of exacerbations or maintenance oral corticosteroids. Omalizumab is indicated in children where their asthma is really triggered by allergic triggers. So they must have allergy with skin prick test or specific IgE. IgE should be within a certain range and the weight as well. And children should have exacerbations in the preceding year, but that's the case for all of them. Mepolizumab is more suggested in children with severe eosinophilic asthma without this typical specific IgE or these typical allergic triggers. And blood eosinophils are important. And that's more or less the same for dupilumab. So if you look at which are the predictors for response, for omalizumab, that's clearly eosinophilia and less FeNO. Allergen-driven asthma is a very important predictor. Childhood onset asthma is a predictor, and BMI above 25. For mepolizumab, it's especially the eosinophils and the exacerbations that predict response, but it's also more effective in adult onset asthma and in patients with polyps. And for dupilumab, eosinophils and FeNO very much predict response to treatment, but dupilumab can also be used for children with polyps and atopic dermatitis. So there are some suggestions how to make a choice between these three medications. And after start of the biological, you need a period of at least 16 to 26 weeks to assess the response. If you have a good response, China suggests to continue for at least 6 to 12 months. Wean other medication like the inhaled corticosteroids, and if patients are doing really well, reconsider the indication of the biological. If children have a poor response, stop your treatment and consider another biological if patients are eligible, but also return to the basics, reassess in your multidisciplinary team. Is our diagnosis correct? Are there modifiable factors, etc.? And there are some other medications except for the biologicals, and I'll show you in a few minutes. So going back to my patient, I started her on mepolizumab in July 2019, and she had a very good response. She didn't have any exacerbation thereafter. I could just decrease the dose of inhaled corticosteroids and LABA to low dose. Her lung function actually remains obstructive, but on a little bit higher level than before. FeNO decreased, and she's really very sportive and is able to do tennis on a high level. She's the number 22 in the Netherlands for her age. But still, I have a lot of questions because it's really difficult how to proceed. Should I try to stop the mepolizumab? The child is not very willing to try to stop it because she really feels good now. So it's not really easy, and I don't have all the answers. What are the new developments? Few for children at the moment. I think a very interesting new development is tezepelumab, which inhibits TSLP, which is quite central, as you can see, in the regulation of T2 immunity. And this tezepelumab in a study in adults also showed some effect on T2 low inflammation. And tralokinumab, ligelizumab, it's difficult to pronounce all those maps, is an anti-IgE. And then we have on the right side, in the T2 low inflammation, several monoclonal antibodies against IL-17, but also some medications against TNF-alpha and etanercept. Maybe probably the best well-known because it's used in some autoimmune diseases. Are there any other new treatments? Well, some developments in the long-acting muscarinic antagonist like tiotropium, which is licensed in children from the age of 12. Effects are not very impressive, I would say. Safety is at least good, tolerability is good, as shown in a study in 6 to 11 years old children. There has also been a small study in preschool children showing no safety issues, but also no effect on symptom days, although there were less exacerbations in the preschool group. Then there are the LABA-LAMA combinations, actually at the moment only registered for adults with COPD. and the ultra-long-acting beta-2 agonist like vilanterol. Another new treatment, well, this is more in a study, in a research study, is a way to target small airways. As you know, small airways are heavily affected in asthma. And with the normal PMDIs and DPIs, it's really difficult to get your medication in the small airways. This is a study from my hospital, from Hetty Janssen. She started children on a smart nebulizer, the Akita, and that's a nebulizer that only gives an aerosol during a slow, deep inhalation, and this inhalation is based on a patient's pulmonary function test. With this method, you can reach a lung deposition of almost 60%. There is less variability because it's really inspiration driven, and you can get more peripheral deposition. We use this Akita in our severe asthma patients. It was not a real study protocol, but as part of clinical care, and compared the number of oral corticosteroid courses 1 year before the start of this nebulization and 1 year after, and we found a significant difference, a significant decrease after starting this nebulizer. Of course, there are a lot of limitations because this is a retrospective study and not a randomized clinical trial, but we still feel that data are robust and that targeting small airways may improve children with asthma as well. So many questions to answer in the future. We need more mechanistic studies also in airway tissue, because airway tissue because non-invasive tests not always reflect what's happening in the airway tissue. Longitudinal studies and non-invasive tests would be preferred, of course. Biomarkers that assess and predict treatment response. Studies on which drug is the best choice for which patient. Long-term effects are, of course, very important in pediatrics, and there are also some suggestions that biologics may have a disease-modifying effect, which is really very interesting, but it has not been shown. Not so many medications for T2 low inflammatory patterns. Comparative studies, there's one study ongoing in the UK comparing mepolizumab versus omalizumab, and we don't have any studies on combinations of biologicals. So you could imagine to combine omalizumab of mepolizumab with dupilumab and really to block your IL-4, IL-5 and IL-13. But most of all, we need pediatric studies. So I'll come to my take-home messages. Severe pediatric asthma is a rare disease in children, and a stepwise approach and multidisciplinary team assessment is very important. And after this MD assessment, in general, you only have a small percentage of children who still have troublesome asthma. Omalizumab is effective in highly selected patients. Mepolizumab and dupilumab, we only have limited data in children, and we really need future research focused on children. I added this slide because you can look up maybe some references if you want to do some further reading. And I'll end with acknowledgement of my team. This is the team of the pediatric pulmonologist and allergologist in my hospital. And as you can see, we are really very happy most of the time. And some of you will recognize at least Jan de Jongste, Lisbeth Duits, and Harm Tiddens, Hetty Janssens. And I will end with this picture of our typical Dutch tulips, which are growing and flourishing at the moment. Well, thank you for your attention, and I'm really happy to take questions.
Thank you very much, Maya. It was wonderful, and it was also very good to see the tulips, because maybe it's also really not the beginning of the cooperation between Dutch and the Turkic culture, and when the period in the 17th century, the tulips were just brought from Turkey, and we borrowed them from Persia and Asian countries. And
okay,
just remarking this, I can say that as far as I found, now our attendees are from 12 countries. including USA, Canada, Kazakhstan, India, and many European countries. So also it was a wonderful talk. Thank you very much. You can just use the chat button. I just start with a question from my friend from Kazakhstan. He is a young pediatrician and very devoted one, and he asks some questions. Many thanks. I'm a pediatrician from Kazakhstan. First question: do you exclude chlamydia, legionella, mycoplasma infection in pediatrics?
Yeah, sometimes we do, but only in selected patients. So that's not a standard, especially not Legionella. But mycoplasma, we sometimes look at mycoplasma, especially if children have local abnormalities on auscultation. And I can read the questions now as well in the chat. Do we have any difference in treatment for obesity and asthma? That's a really very good question. No, there's not a real different treatment. So I think the treatment steps are still like according to BTS and angina. But I think we should try to do at least all efforts to get children moving, to get them to do sports and to try to get weight loss. But of course, I understand that's really very difficult. And another question, when should we exclude primary immune deficiency in severe asthma? Well, in general, we exclude only immunodeficiencies if we see, for example, bronchiectasis on the CT scan, or if we do bronchoscopy and we found abnormal pathogens that you don't expect. So we are not excluding primary immunodeficiencies in children where we don't have other clues than just asthma. And reflux, yeah, that's a really difficult question because lots of children with asthma do have reflux, but if you treat it, the asthma symptoms do not improve. So the question is if this is really an important phenomenon in asthma. The diagnosis of reflux is difficult. In general, we use a pH probe in the esophagus for 24 hours as a sort of a gold standard. But in general, we look at, if we do a bronchoscopy, we look at lip and leden macrophages. But again, it's difficult if it's elevated, if you have to treat it or not. So personally, I don't treat reflux in children with severe asthma.
I think there's another question about weaning the biologics. It's from Dr. Al-Nazir. What's the weaning strategy in your unit? Do you space the dose or reduce it while you're weaning? Mm-hmm.
For omalizumab, how did you say it, Revka? We make the interval longer. So for omalizumab, if children, well, in general, we first, if they have a good response, we treat them for at least 12 months in general. And after these 12 months, if they're really doing well, we tend to increase the interval. So if children are on the 2 weekly injections, they go to 3 weekly injections. If they are in injections once every 4 weeks, we go to once in every 5 weeks, once every 6 weeks. And yeah, then in the end we stop. So we increase the interval. For mepolizumab, I'm a little bit in doubt because the interval is 4 weeks. We're not reducing the dose because that's really difficult as well because of the pre-filled syringes. So we can't reduce the dose there, and that's a little bit the same. Sometimes it's the same in omalizumab, although there the dosages are more variable. And in mepolizumab, we tend to increase the interval to 6 weeks, and if children are doing well, then we stop. But there's no evidence for it, and I think everyone is doing it differently.
Okay, thank you. So Fazet has a question. Which method do you use for BAL cell count and differential?
Wow, that's a good one. We just sent it to our normal lab, and what we ask for is eosinophils, neutrophils, and a differentiation, of course, of the leukocytes. We do a lipid-laden macrophages, and we send in biopsies, especially to ask for eosinophilic infiltration and the thickness of the basal membrane. There's no special method.
May I ask a question?
Yeah, sure.
Yeah. Thank you so much for valuable information, and it was a great speech indeed, especially for about predictors of response to biologicals. In your patient population, what is the rate of severe asthma in asthmatic children?
What is the ratio?
Ratio of severe asthma in all asthmatic children? 5%, 10%?
Okay, yeah. Well, we are at the tertiary care center, so in my outpatient clinic, the percentage of patients with severe asthma is much higher than in a general practice or in a secondary care practice. But if I look in the Netherlands, if we look at the population of children with asthma, the children with severe asthma are less than 5% of all the children with asthma. And from those children with severe asthma, only a minority is eligible for the biologicals. So it's really a rare disease.
Yes, rare disease. Okay. Thank you so much.
We recently had a survey in the Netherlands, and of course we're much smaller than Turkey. We have 17 million inhabitants. And in our survey, around 100 children were on biologicals in our whole country. So that's still a very low number.
Yes, we use omalizumab and mepolizumab at the moment. We haven't used dupilumab in our daily practice.
Mm-hmm.
Yeah. Thank you so much.
Yeah, and if I can ask a question to you, how many children are on biologicals in Turkey? Do you have an idea?
I don't know the numbers exactly, but I'm working in a tertiary hospital, and 10% of all asthmatic children has severe asthma.
Yeah.
Have severe asthma. We don't know the exact numbers.
Yeah. So in my clinic, I think around 30 to 40% has really severe asthma, but that's just the setting. We never admit children with normal asthma exacerbations, for example, to our hospital. They go to the surrounding hospitals, and we only get the asthma exacerbations who need ICU treatment. So that's a highly selected group of patients.
Yes.
And we are trying to set up a registry for severe asthmatic patients in Turkey, because we don't know the exact number, as Ayşen says, but I think it's less than 100, not
Okay.
30, 40, all around Turkey. I don't know. There are many patients on omalizumab, and we are lucky now. Mepolizumab will be available as a licensed drug under 12 years of age soon, maybe in 6 months' time in Turkey. So we will have an experience on mepolizumab widely.
Yeah, I think the children on dupilumab in the Netherlands are mostly the children with severe atopic dermatitis, and it's prescribed by experienced pediatric dermatologists. So I think there are only 5 or 6 children on dupilumab in the Netherlands, and most of the children are on omalizumab. I agree.
We just use dupilumab for atopic dermatitis in Turkey. Not in asthmatic children.
Yeah.
And I wonder the effects of COVID pandemics on severe asthmatic children, not the effect of COVID itself. Because normally our asthmatic kids are doing better. Our severe asthmatics are in a better position now, better condition now. Is it the same in Netherlands, or what's the position?
Yeah, I only can tell my personal experience, and yes, many children, not only with asthma but also with other respiratory diseases, are doing really well, much better than we expected. we did not have a single infant with RSV bronchiolitis in the Netherlands, which is extremely uncommon. So in general, that's our main population in this time of the year on the ICU. There are no patients with influenza in the Netherlands, which is also very uncommon. And for the children with asthma, we did not admit children with severe asthma attacks based on COVID. We have now at the moment quite some asthma because the schools started again 3-4 weeks ago, the primary schools. And well, we have 2 kids on the ICU now with the rhinovirus triggered asthma attack. So it has been the same situation as in Turkey, I guess. We had less asthma exacerbation during the lockdown, but the numbers are going up again after the schools started.
And in that position, I am questioning the effect of allergy on severe asthma. Because everybody is locked down at their home and more exposed to house dust mite. But even the kids with house dust mite allergy, they are not doing worse.
No, yeah. I do not know all the data about COVID and asthma, of course, but there have also been suggestions that in children with allergic asthma, ACE2 expression in the bronchial epithelium is less, so suggesting that COVID cannot enter the respiratory tract as easily as in healthy children, or especially in healthy adults, I would say. So maybe there may be even some sort of a protective effect that COVID cannot enter as easily the respiratory tract because of less ACE2 expression.
Thanks, Marielle. Maybe can I ask a question? Also, there is a tulip connection to Canada. There's a tulip festival in Ottawa in May because the Prince, I think the Queen of Holland, resided in Canada during the Second World War.
Yeah.
They donate tulips every year to Canada, and there's a really nice festival. So there are some conflicting data, some support and some doesn't support, but especially in obese children with asthma, if there is a existing obstructive sleep apnea, the treatment may improve the asthma outcomes. There are some like big data analysis, some case analysis also, which we did in collaboration with Ankara Group. So what's your personal experience? Is this something you think that would be contributory?
Yeah, I think you have much more experience here than I have, Refika. We did not pay a lot of attention to sleep disordered breathing and OSAS till recently in the children with severe asthma, but now we have a pediatric pulmonologist interested in sleep as well, as you know. So we have more attention for that now. But maybe that's a question to you. Do you have the impression that, for example, montelukast might be an option in those kids?
I'm not sure. I think the kids that I follow with severe asthma, obesity, and obstructive sleep apnea have also a lot of issues with psychological sort of problems and have a hard time with CPAP therapies. So, I mean, they respond at best 50% to adrenal tonsillectomy. And there's a suggestion that in obese kids, maybe montelukast is not as effective, which is also the same in my experience. So I'm not sure the montelukast or surgery is that effective. The best is probably to use the CPAP, but I see a lot of, in my personal experience, adherence issues with that as well. So it's a data out there, but I have never seen a child like treated with obstructive sleep apnea and the asthma if all of a sudden is much better.
Yeah.
That's why I was wondering how it was. But maybe in younger non-obese kids, montelukast could be trialed with the new black box warning. I'm always more careful with that, but it could be an option for all younger kids. Any other questions? I don't see any more questions in chat. Brancham, do you have any other questions, or do you
I
see
think
any?
it's we have 70 minutes now, 70 minutes left, and then
Okay.
really it was an excellent. Oh, our one of our attendees from Chile is just participated, but okay. Sometimes this GMT +3 +2 because Turkey is now not using the winter time application, so it's just a little bit messy. Sometimes people are attending 1 hour later or 1 hour earlier. So I would like to mention that they will not miss this excellent talk. They can catch it with the permission of Marielle. Thank you very much for that. They can catch this via our YouTube channel. So I would like, on behalf of our society, I would like to thank you all. It was very, very good and inspiring the young physicians in Turkey. And also I'm thanking to all participants because there were allergologists, immunologists as well. So, and physiotherapists from Lebanon also attended this
Good.
meeting. So I think it was so inspiring talk and just gathering the whole bunch of information in a very good sense. Thank you very much, Maria, and hope to see you soon face to face.
Yeah, it was a great pleasure, and I cannot agree more. I hope to see many of you in Barcelona or at another occasion. So thank you very much for the invitation. I much enjoyed.
Thank
Thank you,
you.
guys. Bye.
Thank you
Bye
very much.
bye.
Thank you, everyone.